for your time.
Thank you very much to presenter, Dr. Your name is very hard, Cyriaque. Thank you so much for your time and for giving us this wonderful, wonderful talk. And I like what he said, consult, consult, consult. Let's feel free to always reach out to places where we know we will get the much needed assistance that we require, it so that we give the best to the people that we serve. Thank you all for the participants, everyone who's attended, everyone who's listened and asked questions. We really value your attendance and your input. Just of note is tomorrow we will have our webinar, but our webinar will be at 7 to 8:30 p.m. And in this webinar, it will be an interesting and a shift from what we are normally used to. And we'll be talking about sexual harassment, sexual exploitation and abuse within our workplaces, within our workspaces. So it would be nice to join and hear about it, and we'll all learn how to prevent and mitigate sexual harassment within our workplace. Thank you very much for everyone who's attended. Up until tomorrow at 7 p.m. Have a good evening, good day, and see you tomorrow. Thank you.
Thank you so much.
If you have levels of 5.5 to 6.4 millimole per liter, do you still bind? What do you do? We seem to have lost Dr. Cyriaque. Let's try and get him on the line so that he can finish answering a lot of your questions. However, in the meantime, I can see there are several questions on CPD points. So I will answer on that. As I had said earlier, especially for pharmacists, the mode of getting CPD points is by self-reporting, even as we are trying to solve the issue of having this on the portal. So what you do is, once you go to the PPB online services portal, you'll see an area where there's private practice details and self-reporting. Kindly go to the self-reporting section, and it is there where you'll see the category name, the event that you attend, the location of the, if you have levels of 5.5 to 6.4 millimole per liter, do you still bind? What do you do? Millimole per liter, do you still bind? What do you do? Hi, Dr. You might be on mute. We seem to have lost Dr. Cyriaque. Let's try and get him on the line so that he can finish answering a lot of your questions. However, in the meantime, I can see there are several questions on CPD points. So I will answer on that. As I had said earlier, especially for pharmacists, the mode of getting CPD points is by self-reporting, even as we are trying to solve the issue of having this on the portal. So what you do is, once you go to the PPB online services portal, you'll see an area where there's private practice details and self-reporting. Kindly go to the self-reporting section, and it is there where you'll see the category name, the event that you attend, the location of the event, which now will be KNH-UON, the duration, which will be now for 1 hour, 30 minutes, and the date you attended, and the activity description. When it comes to evidence, feel free to email us, and we'll email you the attendance list for the webinar session that you have attended, and you'll be able to submit this to PPB and get your CPD points. For now, that is the mode we are using, even as we try and resolve the issues in terms of having this uploaded. Thank you. Daktari is back. Dr. Cyriaque?
I'm back in some disease conditions, but other ones, no. So for children in hypercatabolic state, sepsis, burns, crash injury may require more aggressive dialysis than other children. And dialysis may be considered even if the renal failure is not severe, as I said, when there is a need for removal of the fluid, in case of the fluid overload, give a blood product or nutritional support. So now what is the modality of dialysis? So modality of dialysis in the children is the same with adult. But in children, most approach is peritoneal dialysis because it's very easier to fix the PD catheter. It is difficult to get now the adequate machine which can have the blood, to get the blood line, to get the dialyzer, to get the blood volumes in the children, it's quite challenging. So usually we consider peritoneal dialysis. So you have also intermittent hemodialysis, continuous renal replacement therapy, and sustained low efficient dialysis. So usually those two, the last approach, continuous renal replacement therapy and sustained low efficient dialysis, are the approach we are using for the patient who are hemodynamically unstable. What are the factors influencing now the choice of the renal replacement therapy in children? One is the goal for dialysis. So if you consider atrial fibrillations, you consider if the child has, for example, above 25 kilos, you can get the vascular access and the machine can do dialysis. So if you have the fluid overload, the hemodialysis is better than peritoneal dialysis in the case to remove the fluid very fast because you can set in the machine how amount of the fluid you want to remove. But if you want solid clearance, the peritoneal dialysis is better to remove the toxin than hemodialysis. So also you consider clinical status of the child and hemodynamic stabilities. Any child who has lower blood pressure, any child who has bleeding tenderness, you consider peritoneal dialysis because it is safer than hemodialysis. Also, you consider feasibility of peritoneal or large vascular access. So if the child has lower vascular access, especially for the small children, so you consider peritoneal dialysis. Also, the factors, other factors, how your personnel, how personnel you have, how institutional preference, what you have experience. So that one may guide the clinician to make the decisions. So if the child needs anticoagulations, so it's better to go for the peritoneal dialysis than hemodialysis. Also, sometimes you may consider the cost of the treatment and the supply you have. If you don't have, for example, the requirement for hemodialysis, you can go for peritoneal dialysis as vice versa. So we can look, for example, this clinical scenario of 10 days old infant who was admitted with refusal to breastfeed for 2 days, inability to pass urine for 1 day. And clinically, the child the neonate was sick looking, dehydrated, had data spirit, deep acidic breathing with the conversions. So the birth weight was 3.5, the admission weight was 2.8, and the length was 50 centimeters. So the investigation done, urea was 67 micromole per liter, creatinine 670 micromole per liter, sodium 196, potassium 80.2. So when you use now that formula, I said it modified Schwartz formula. So we see now the GFR for this unit, it's come at a 2.9 millimoles per minute, which is very low. So when you consider now P-RIFO criteria, this child is in failure because the normal creatinine level for the children for 2 weeks is supposed to be around 38, 38 minus plus or minus 6. So, but now to have a GFR of 2.9, so it's meaning the creatinine clearance has been reduced more than 75% of the normal one. So, also what you consider, this child is conversing because has the high urea. So also you support to consider other causes of the conversion, like for example, calcium and the random blood sugar. So this child has sodium, which one is 196, which can cause now the brain tear, the blood vessel of the brain to have tearing and bleeding intra-hemorrhage. So also another risk factors is hyperkalemia. So when we did the white blood, he said it was 20, that was neutrophilia, the leukocytosis, neutrophilia of 87%, with normal hemoglobin, with thrombocytopenia. So when you need the blood gas analysis, so we found now pH at 7, bicarbonate 9, base excess 24, and anion gap of 44. What's the way for management? So this child now requires the IV fluid. So IV fluid for the children who has hyponatremia. So you take now the dextrose plus half normal saline, and the formula is due to the usual maintenance of fluid plus between 30 and 60% of the requirement. So this child was supposed to have to bind the hyperkalemia. So that one I said for the previous presentations. So we're supposed to correct acidosis. We're supposed to give IV antibiotic according to the renal dose, and you consider dialysis. So you don't forget to supporting catheterize, monitor your glucose, and monitor your blood pressures. So this in the slide. Here, this child now went in the renal unit. So you can consider the child is under oxygen. It has the catheter which is providing the IV fluid. So here you can see the PD catheter in situ, and there you can see the urinary catheter in situ. So those are the children who need intensive care unit, but because we don't have adequate beds and enough bed, so we do the miracles in our renal unit, and most of the children, they recover. What is our experience in Kenyatta National Hospital? So we found more than 80% of the AKI are caused by the neonatal sepsis. So, however, the best when you compare with other scenarios, in the other setting, our children, they are doing better. Maybe one of the reasons is because our AKI in children, it's mostly caused by the prerenal cause, but elsewhere in Western, the AKI is caused by the forced cardiac surgery, cardiac bypass. So those children, they have poor outcome. So, but in our setting, more than 80% of the children are recovering well. They gain the normal kidney function test, they improve, then they go home. So in most of the study done, there's 2 studies done. The recent one was done last year by Dr. Ivan. He found the mortality of AKI was 10%, so which is encouraging, and that gives the hope for those children. So, however, we found this poor outcome in children admitted in critical care unit and the pediatric intensive care unit. So, what is now our take-home message today? So, AKI is an independent factor of outcome in hospital setting. So, earlier diagnosis and referral is crucial, especially for those children who come in other facilities. It's better to make the diagnosis earlier and refer at earlier times. Supportive therapy is very important, and the area dialysis is life-saving. So PD catheter, the peritoneal dialysis modality for choice for replacement therapy in children. Thank you so much for your attention. Now it is the time for questions and answers.
Thank you very much for that presentation. I think it was very, very clear in terms of managing acute kidney injury in children. And I love this presentation because it reminds us of how we should be able to take care of our patients from wherever we are. So right now we'll have a few questions. So the first question is from Dr. Kalemia. What level of hyponatremia do you start correcting?
So the normal potassium level is 3.5 to 5.5. So any potassium above 5.5 is considered hyperkalemia. However, so if potassium is less than 6.5, so it doesn't require emergency binding. So now what you can consider, you give your fluid for the patient, because usually it's associated by, if you give your fluid, you operate acidosis, and you repeat your EECs or blood gas analysis after 2 hours. If you found after 2 hours now the potassium still above 6, now then you can start binding. So I think that's the answers.
Thank you very much for that answer. There's a question from Clifford Amaganga. Is there a significant causative contribution to acute kidney injury by indiscriminate use of NSAIDs?
So inside they have the issue of increasing and the worsening AKI and chronic kidney disease. So I'm not recommended in AKI. We are not using any NSAID in AKI.
I think the question he's asking is whether
Yes.
AKI can cause, whether use of NSAIDs can cause AKI.
Yeah. So if you are using NSAID, it can cause AKI, that's true. But so if the patient has normal kidney function test, so it's very rare to have NSAID with AKI. It's very rare. However, for the children who has chronic kidney disease, if you are using now NSAID, that one can precipitate AKI, and then you have AKI on chronic kidney disease. But for normal patient, normal children who has normal urine output, normal kidney function test, as long as the dose is adjusted according to the weight, so it's very rare to have NSAID with the AKI. It's more relevant for the chronic kidney disease because it precipitate AKI on chronic kidney disease. Or if the child has another underlying other disease like the cardiac lesion, liver disease, so those one NSAID precipitate AKI. But for normal children, it's very rare.
Thank you very much for your response. There's another question also on the fluid or the Lasix challenge. So how many times can you give it? Can you repeat this challenge? When do you repeat the challenge, and how do you decide on whether to use 2 milligrams per kg or 4 milligrams per kg for the Lasix?
Basically, for the fluid challenge, you give it once, because so there is a disparity in the fluid challenge as the diagnosis, and the fluid challenge as those the people they think you are increasing your circulatory volumes. So if the child comes and you don't know if the child has prerenal AKI or increasing AKI, that's where you found, for example, the child in coma, maybe the child, the one who brought the child, there's no other history you have. So if the child reported to have anuric, you will give the fluid challenge. So the fluid challenge you can give normal saline. For the smaller children, you give 10 ml per kg, but for the above 1 month, you can give 20 ml per kg. So after giving that fluid challenge, so we give now Lasix. So Lasix you can give between 2 and 7 milligrams per kilo per dose. So they recommended the one because you are not shutting the kidney, it's better to give the lower dose, 1 to 2 milligrams per kg. So if there's no urine output, you are no longer using the Lasix, and you are no longer giving other bolus, because you know the patient either has intrinsic kidney injury, and that's what you need to know to calculate the normal maintenance fluid and to organize the peritoneal dialysis. Or either your patient may have severe septic shock and hypovolemia. This is the child who may need inotropic support, but not shutting the kidney with the Lasix. So I think it's clear. So you give it 1 to 2 milligrams. You give only around 7 milligram. When is the patient who comes, they have been reported the anuria, but clinically you found the patient have sign of the fluid overload. So that's when you can give a higher dose of molasses to force down the diuresis.
Thank you very much for that. There's a question here from an anonymous attendee. I'd like to understand the use of insulin to manage hyperkalemia in neonates.
The insulin. So when you give a insulin, it's facilitating shifting of the potassium from intracellular to extracellular. So no, from extracellular to intracellular. It's the same way even for adult. So the insulin and the action of the insulin is very fast. So the role of the insulin is to shift now potassium from extracellular, which is having in a vascular compartment, to intracellular, so that at least you can reduce the complication of the potassium. That's the role of the insulin.
I think the question is more, how do you use it when it comes to neonates?
So for the neonate, you use a 0.05 international unit per kilo per dose. So 0.5 international unit per kilo per dose for the neonate, not 0.1. 0.1 is the children above 1 month. However, also it depends how the severity of the potassium and how the random blood sugar. So if the child, because some of those children, because inflammatory mediators, they may come with hyperkalemia and hyperglycemia. So you see, the management you take for the child who has potassium of 9 and the random glucose of 27 will be different with the child who comes with potassium of 7 and random blood sugar of 4. So if the child has both hyperkalemia and hyperglycemia, so you give a higher dose of 0.1 international unit per kilo per dose. So the management is individual. So every patient is unique. So you consider each patient according to the clinical scenario and your laboratory findings.
Thank you very much. There's a question here from Festus Keegan. How common is AKI in children on cancer chemotherapy, even within our setup?
I don't have the figures, but it depends on which type of the cancer, because AKI is more common for the children with the AML and the ALL and the lymphoma. Because other children who have AKI are those one who has, for example, the germ cell tumors, which are complicating now, which are blocking now the ureters, scrotal tumors, complicated those tumors, or the children who have the ovarian cancer. So if you have ovarian cancer, as Dr. Mokomba said the last times, so those they have higher risk to have AKI. But for other children who have rhabdomyosarcoma, are very rare to have AKI. Rhabdomyosarcoma, osteomyosarcoma, AKI is very rare. So only those entities, ALL, AML, lymphoma, and most of the germ cell tumor which are obstructing now the ureters. So other tumors are very rare to have the AKI. Apart, if the time to give chemotherapy, the child missed adequate hydrations and was not receiving adequate hydration after chemos. So that one you can get the AKI. So because I remember I saw 2 children with AKI who has the tumor of the retinoblastoma. So it is not more common, but because now the hydration status was not adequate before in the prior chemo, those children developed the AKI. So I don't have all the figures for the neonatal or other children with cancer who developed the AKI.
Thank you very much for that. There's a question on correction of hyponatremia. So how do you correct hyponatremia when a child has dehydration at the same time?
So there is so many formula to correct hyponatremia, and I think it's not easy for everyone, but the simple formula you can use, because Each child who has hyponatremic dehydrations, so has both intracellular and extracellular dehydrations. So now, this is the child who is supposed to calculate the free fluid levels and the normal maintenance. Now to simplify, to make it very simple to calculate the maintenance fluid. For the maintenance fluid for that child, you're supposed to take the normal maintenance fluid, then you add between 30 and 60 ml per kilos of the requirement. I can give you an example. Let's assume the child who has 20 kilos, it has sodium of 190. So the normal maintenance fluid for this child is supposed to be 1,500 mils. So now, if the child has hyponatremia, what you will do, you will take now another 30 mils. So 30 mils and 60 mils per kg. So now you will take between 1,500 mils plus 1,600 mils to 1,200 mils. Now, because sometimes you may deal with always when you make the decision, you remember when you prescribe the drugs or the fluid, you remember how the burden of the nursing in the ward, how the work it is. So in case now to avoid the fluid overload for this patient, because you don't have the pump to operate now hourly, so you can have now intermediate. So you take this 2,000 plus 600, which is 1,800 divided by 2. So that one will give you 900 mils. So then plus 1,500. So this child you can give it 2,400 mils over 24 hours. However, we support to create sodium not more than 15 milliequivalent per kilo per day. So approach is between 10 and 15 milliequivalent per kilo per day. But this is the simple formula you can use. And once you give now the fluid, you give dextrose and half normal saline. So because when you give half normal saline, the water will disperse in both intravascular, interstitial, and intracellular compartment. So normal saline will remain intravascular compartment and the interstitial compartment, and the dextrose will go now intracellular compartment. So when you give dextrose half normal saline, so you try to create both compartment, intracellular, interstitial, and intravascular compartment. That's how we create now hyponatremia.
Thank you very much for that answer, and it answers quite a number of questions. There's a question also on the management of hyperkalemia. What happens in that where it's borderline high hyperkalemia, like if you have levels of 5.5 to 6.4 millimole per liter, do you still bind? What do you do? Hi, Dr. You might be on mute. We seem to have lost Dr. Cyriaque. Let's try and get him on the line so that he can finish answering a lot of your questions. However, in the meantime, I can see there are several questions on CPD points. So I will answer on that. As I had said earlier, especially for pharmacists, the mode of getting CPD points is by self-reporting, even as we are trying to solve the issue of having this on the portal. So what you do is once you go to the PPB online services portal, you'll see an area where there's private practice details and self-reporting. Kindly go to the self-reporting section, and it is there where you'll see the category name, the event that you attend, the location of the event, which now will be KNH-UON, the duration, which will be now for 1 hour, 30 minutes, and the date you attended, and the activity description. When it comes to evidence, feel free to email us and we'll email you the attendance list for the webinar session that you have attended, and you'll be able to submit this to PPB and get your CPD points. For now, that is the mode we are using, even as we try and resolve the issues in terms of having this uploaded. Thank you. Daktari is back. Dr. Cyriaque?
I'm back. There was a network issues, but I'm back.
Yes.
Hello.
Hello, you can hear us?
Yes.
On the issue of, you were answering the issue of hyperkalemia between 5.5 and 6.4?
Yes.
Yes.
So issue concern with hyperkalemia between the 5 and the 5.5 and the 6.4. So usually you start with avoiding to give another potassium. The potassium in our fluid, that's why you use the normal sign, not than ring as lactate. So if you are enteral feeding, it's contain the potassium, you remove from the potassium. And if the child can feed, you can give now not all binding, but you can give Kayexrate so that you can remove the potassium. However, because most of our patients are the neonate, and those neonates, they cannot take a Kayexrate, and it's not available for formulation for the neonate. So because the most of the potassium we get is hemolyzed. So sometimes it's hemolyzed because there is a delay between taking the sample and to analyze. So now the best option, take the blood gas analysis. If the blood gas analysis showing now the potassium above 6, so it's better to start now binding. So you can give now the insulin, as I said, and glucose, because that one alone can reduce that potassium, which is between 5.5 and 6.4, without binding on those drugs. So then you repeat blood gas analysis, that at the same time you can repeat the UECs in the renal lab. So if you found now the potassium has been increasing, so you have two options. One is to bind with all those the drug, all of them, and the second one is to start for the dialysis, because always you consider the patient is dynamic, and so approach is dynamic, because once you have the result, you assess clinically, you give your medications, you put your fluid status, you put your acidosis, so then you found. However, what I can just highlight kidogo, if the child who has hyperkalemia, who has hyperkalemia, yes, and has severe metabolic acidosis. If the acidosis is not corrected, so the potassium will not be corrected, because when the pH is increased at 0.1 unit, the potassium is increased at 0.3 to 0.6 unit. So that's why we found most of the patients with severe metabolic acidosis, they have severe hyperkalemia. So our approach it's global, not only focus on potassium. So you focus for the blood gas analysis, your intake. So if the patient also has other cause of the increasing potassium, for example, rhabdomyolysis. So those one you consider the dialysis even if the potassium is 5.5, because this patient who has rhabdomyolysis or hemolysis syndrome, the potassium will be very high before at the end of the day.
Thank you very much. We'll take the last question from Rumesa Akmal, who's asking, in terms of fluid challenge, this is given after correcting hydration, right? Not before.
No, the fluid challenge is given for the first attendance of the patient. If you attend the patient, just the idea for the fluid challenge is to make the diagnosis for the patient has intrinsic renal failure, or if the patient has pre-renal failure. So when you give a lysis challenge, the fluid in the lysis challenge, the patient is not passing any urine. most of the time the patient either has intrinsic or prerenal. So, this patient will not recover even if you give a lot of fluid. So the best option is now to prepare for dialysis. So usually for the fluid challenge and the last challenge, most of the older school, they consider as the way, for example, to force the diuresis. But in terms of the nephrology, for us not to force the diuresis, is to know if the patient has prerenal AKI or intrinsic AKI. If there is no urine output, this patient, even if we give a lot of fluid, he will not or she not make the urine. Now the best solution is to prepare dialysis as soon as possible. So that's the role, the main role and the key point of the fluid challenge.
Thank you very much. We've come to the end of our session. I'd like to give the presenter a minute or two to give the closing remarks, what he'd like us to be keen on or take home, even as we manage our children from wherever we are. Dr.
Thank you so much, Dr. Nancy. What I can share with our colleagues, AKI has higher mortality, especially for those working in the ICU or critical care. They know how the severity of AKI. So, and the AKI is preventable, especially for the children who has vomiting, the diarrhea. Just is required to give the IV Branila as soon as possible. You give your maintenance fluid or you give your ORS. So for those whom we can prevent, especially prerenal AKI, diarrhea, vomiting, so those one you can prevent as giving now the adequate hydrations. However, in case someone missed the line, you can use intraosseous to give the IV fluid, or can use an nasogastric tube to give the fluid. And if now you found the patient is not improving, refer earlier. Another comment I can add for our colleagues is to measure always the estimated creatinine clearance. Because what happened most of the children, the people, they forgot to measure the creatinine clearance. What happened, can I give you an example? A child who has, for example, 2 years, who have now creatinine of 100. When you consider, for example, our unit of the creatinine, you find that the creatinine is abnormal. But a child of 2 years usually has the height between 90 and 95%. When you calculate the GFR, 40 times now 90 divide creatinine of 100, you find that the child has a GFR of 40 or less than 40. So which the child has injury. So the best always once you have a child is to calculate GFR and to know how burden we have as now the AKI. So another entity I can add, the consult area for the nephrologists, even if the nephrologists are still few in the countries, but you can call in Kenyatta, you can get assistance. So Kenyatta has at least one nephrologist pediatric, which is Dr. Okero. So, and we engage now for the fellowship in nephrology, because as I speak, we have now 5 fellow in nephrologists, 2 senior, me and Dr. Rachel, and you have other 3 junior nephrologists. So hopefully we can encourage other doctors to come and join us for the nephrology, because we may save all those children. So thank you for your time.
Thank you very much to presenter, Dr. Your name is very hard, Cyriaque. Thank you so much for your time and for giving us this wonderful, wonderful talk. And I like what he said, consult, consult, consult. Let's feel free to always reach out to places where we know we will get the much needed assistance that we require, so that we give the best to the people that we serve. Thank you all for the participants, everyone who's attended, everyone who's listened and asked questions. We really value your attendance and your input. Just of note is tomorrow we will have our webinar, but our webinar will be at 7 to 8:30 p.m. And in this webinar, it will be an interesting and a shift from from what we are normally used to, and we'll be talking about sexual harassment, sexual exploitation, and abuse within our workplaces, within our workspaces. So it would be nice to join and hear about it, and we'll all learn how to prevent and mitigate sexual harassment within our workplace. Thank you very much for everyone who's attended. Up until tomorrow at 7 p.m. Have a good evening, good day, and see you tomorrow. Thank you.
Thank you so much.